Hello, this is Janet Michael. In addition to hosting The Valley Today each weekday at noon on the River 95.3, I also produce podcasts. And I'm excited to kick off Season 2 of our podcast series in partnership with Rappahannock Electric Cooperative. It's called We Are REC. Every week we'll release a new episode talking to different people from REC about a host of different topics. We'll get tips for saving money on your electric bill. We'll talk about renewable energy and the impact it can have in our communities. We'll get some behind-the-scenes info about what happens when the power goes out in a storm. Don't miss out on information about community grants, scholarships, REC-hosted events, and more. Get every single episode on our website at theriver953.com under the podcast tab, or you can subscribe for free in Apple Podcasts, Google Podcasts, or on Spotify. Just do a quick search for We Are REC. Hello and welcome to The Valley Today. I am your host, Janet Michael. We are pre-recording today's conversation. You, of course, are listening to it on a Thursday afternoon. We are recording over Zoom on a Tuesday morning for a conversation with Dr. Paul Lyons. He is a neurologist and an epileptologist. This is part of our community health series in partnership with Valley Health. Every month I talk to various doctors, administrators, program directors from Valley Health about a wide variety of health topics. And Dr. Lyons, I appreciate you taking some time out of your schedule this morning to have this conversation with me and give me a little bit of a education on epilepsy and some of its treatment protocols.
Excellent. Thank you so much for hosting this program and helping me educate the community. I appreciate your time.
When I introduced you as a neurologist and epileptologist, and by the way, that took a couple of days of me saying over
No, I
and over
appreciate
again.
that. That's part of the, that's part of the prerequisite to finish your fellowship. You have to say that without difficulty. So I'm really impressed, actually.
But you are also the medical director and co-founder of the Virginia Comprehensive Epilepsy Program at Winchester Medical Center. And I know we're going to talk about some of that in a little bit, but can we start with the basics and tell me what exactly is epilepsy?
That's a great question. So epilepsy, as most people might identify, is associated with seizures, but like most human diseases, is actually a syndrome. So the formal definition is twofold. The International League Against Epilepsy some years ago established very clear and very simple definitions. There's two ways that people can be diagnosed with epilepsy. One is if you've had two or more unprovoked seizures separated by 24 hours, and we'll talk about what an unprovoked seizure is. And the second definition, a separate definition, is one unprovoked seizure and risk for recurrent seizures such that you have an abnormal EEG. So you can see that the definitions are largely clinical, and in some cases EEG or electroencephalography testing based. So an unprovoked seizure is what occurs as a primary disorder of brain circuitry and electrical circuitry, which is in essence what epilepsy is. Not all seizures are unprovoked. So for instance, if someone has diabetes, let's say, and they inject themselves with insulin, forget to eat, and the blood sugar gets quite low, close to zero, they'll have a provoked seizure. If someone accidentally abruptly stops, say, their muscle relaxant, they can have a provoked seizure from medication withdrawal. So those are not part of epilepsy. Likewise, most febrile seizures that are not uncommon among children 6 years and under are not considered provoked seizures.
Is it a common syndrome? Do a lot of people have it?
Epilepsy is a group of syndromes is quite common. It occurs about 1% of the population. It is more common, meaning above 1%, in individuals or babies 1 year and under due to, we think, things related to birth and the first months of life or even gestational history. The second population that had higher risk, and that's quite interesting as it relates to our population in the nation, is individuals over 65 years of age have an increased risk of epilepsy and actually steadily goes up every year you're alive. But in general, it is relatively common, meaning 1% of the population, meaning about 3.2 million Americans have epilepsy.
And is it something that is genetic? Is it hereditary? Are you born with it? Do you not know you have it? I guess you mentioned earlier that sometimes it's later in life before you are really diagnosed. How do you know? Are there tests for it?
There's three very good questions there. One is that epilepsy in one person, say a baby, versus a child versus an adult, are distinguished from one another based upon the epilepsy syndrome. So we've talked about epilepsy broadly, but epilepsy syndrome itself has three components to its definition. And this is how we distinguish one person with epilepsy from another. The first part of the definition is who you are when the seizures begin. Are you a baby? Are you a child? Are you an adult? Are you elderly? Are you normal developmentally, or do you have developmental delay? That's the first criterion. The second criterion would be what the EEG shows, or what the brainwave shows. The third component, or third criterion of this definition of an epilepsy syndrome is what the seizures look like, or what we say the seizure, quote-unquote, semiology. Is it lip smacking, hand clicking, laughing, hopping, dancing, running, staring? All those can be symptoms of seizures. So the second part of your question is, can they be subtle, or can they be difficult to diagnose? So certainly. As I've mentioned, not all seizures are convulsive. They can be very subtle. Even spells of deja vu or funny smell or funny taste can be symptoms of a seizure. A study done in Melbourne, Australia, identified that approximately 40% of patients who presented to an emergency department with their first convulsive seizure actually had had their first true seizure a year beforehand. So in the last 6 months, I've seen patients whose initial symptoms of seizures include anxiety, panic attacks, funny taste or smells, or a sense of deja vu. So it can be quite subtle at onset and can take a while to be diagnosed. In that regard, sometimes seizures only arise from sleep, in which case, unless someone is witnessing the person, observing the person when they sleep, they can also be sleep onset and restricted sleep. An additional challenge in diagnosing epilepsy is most patients with seizures are amnesic to the seizures. That's a hallmark of seizure versus syncope or fainting. And so if the patient is not witnessed to have a seizure, unless they fall or hurt themselves otherwise, they may not know that they've had a seizure. I've actually had patients only come to diagnosis of epilepsy when they become married and their spouse identifies something unusual. They stop speaking in the middle of a conversation non-purposefully, or they develop unilateral limb shaking arising from sleep. And there is testing, the third part of your question. MRIs can be helpful in assessing risk factors. EEG, of course, is part of the definition. In general, in anyone with epilepsy or any person, there's 4 risk factors for epilepsy. Abnormal MRI, as I've mentioned, abnormal EEG as part of the definition, abnormal development in childhood and young adulthood, and abnormal neurological exam. So those are some of the risk factors, some of the challenges in diagnosing early, and some of the tools that we can use to diagnose epilepsy. But a cornerstone or a hallmark of treatment and diagnosis of epilepsy is clinical. You have to get the story right to begin with, because you can have false positives and false negatives on testing, and ultimately you have to treat the patient based upon the symptoms and their history and a clinical impression.
I know from reading your bio that you focus a great deal on pediatric epilepsy. Why was that of particular interest to you?
One, I like playing with kids, and they're a lot of fun. Not that adults aren't fun, but you can make a child happy with a sticker or a fancy bandage, and I like those too. So I like engaging children that way. Secondly, the vast majority of patients with drug-resistant epilepsy, which is what I focus on, meaning patients with epilepsy that don't respond to seizures, actually have their seizures begin in childhood, and that's been demonstrated in lots of clinical studies. So actually, epilepsy is a lifelong syndrome. What I've learned in my practice over the 16 years I've been here is what I learned in the adult population helps inform children and their adults to guide treatment options and decisions for adulthood. And likewise, what I learn in childhood can help me inform causes of epilepsy in adulthood. And then thirdly, childhood is a very unique time in development, meaning what a child does at 4 really can't be replicated at 5, nor 5 can be replicated at 6. However, an adult, frankly, for most adults, what you do at 25, you could probably do at 35, and likewise, you could probably do at 45. So in childhood development, there's developmental windows that open and close. And a major element of epilepsy, both for children and adults, is cognitive deficits that are results of these electrographic seizures and abnormal signals. And so it's particularly gratifying in children, such as a case I've had recently with a little girl with severe epilepsy who lives in Northern Virginia, who has a hematological disorder, followed at Children's Hospital, who I first met with very severe epilepsy and associated regression, poor language, poor eye contact, poor motor skills, and just not thriving as a child. Ultimately, with the use of a medication, later which we'll talk about, specifically Epidiolex, the child became essentially seizure-free, but just as importantly, is now vivacious, engaging, precocious, enjoys ironing her clothes, runs around the house, gets into adventures, and she's just a delight now to see, and the family obviously is quite happy, not just with the seizure freedom, but with the developmental element. This touches upon a big part of epilepsy as a syndrome. Like many diseases, epilepsy is, by analogy, can be described, or metaphor really, can be described as being like an iceberg. As you may know, the small part of the iceberg is above the water, and the big part of the iceberg is below the water. And so likewise, although we think of epilepsy as being seizures, a major part of epilepsy is cognitive deficits, changes in mood, learning, attention, personality, senses of humor, visual learning, auditory learning, concentration. All those are the results of abnormal electrical circuits that occur over months and years. So again, all those elements of how epilepsy is typically, particularly in drug-resistant epilepsy, a lifelong process and phenomenon, and my natural disposition to be somewhat playful with kids in positive ways drives me to focus in particular on kids whenever I can.
So I mentioned at the top of the show that you're the medical director and co-founder of the Virginia Comprehensive Epilepsy Program at Winchester Medical Center. What is that exactly?
For patients I've mentioned before with drug-resistant epilepsy, and as I haven't mentioned yet, about a third of all patients with epilepsy, so about just over 1 million Americans, have daily, weekly, or monthly seizures despite appropriate anti-medications. And so that's what we focus on. So when a patient fails the first 2 seizure medications they've been on, with most medications, the probability of seizure freedom at that point is 1 to 5%. And so knowing that quality of life is strongly correlated with seizure freedom, not just reduction in seizures for many patients, then focusing on achieving seizure freedom involves a whole team. And so what we've done with the support from a whole host of departments, being neurosurgery, dietary, the ICU, medical imaging, nuclear medicine, interventional radiology, neuropsychology, as well as nurses across all the wards of the hospital here in Winchester, were able to render services to the patients based upon their needs, be it new onset seizure in a child who has seizures that go on for days, a young adult who hopes to be seizure-free to go off to college, who needs to have epilepsy surgery with Dr. Selznick, and in the OR identify a seizure focus and remove it successfully without harm, or implanting metal devices that can achieve seizure freedom, such as VNS or NeuroPace, or lastly, engagement in clinical studies such as those that we participated in to help move medical CBD or Epidiolex into FDA approval. So for patients who have difficult to treat epilepsy, a comprehensive epilepsy program such as that we have here in Winchester can help patients achieve their goals, in this case seizure freedom without side effect, with all those team members that are required. Not everyone needs to have such resources, but the point of marshaling all of those in one place is to make sure that the designation of a level 4 comprehensive epilepsy program assures the patient that whatever they need, they'll be able to have access to at that program and its associated facilities and clinicians.
And being a level 4 is a big deal. There are only 3 centers in the state that are at level 4 that treat both adults and pediatrics, right?
That's right. Yep. And so we've with the help of the leadership from Valley Health as well as Winchester Medical Center and all those people I mentioned, including my partners and of course the patients who work with us to achieve seizure freedom, we've been able to achieve that and maintain it and build upon that to make sure that we can offer the very best care locally.
Well, let's take a quick break. When we come back, can we get into the weeds a little bit on treatment protocols? You mentioned a second ago about CDB oil, and I want to talk about that. Epidiolex is one of those treatment protocols, clinical trials. Can you explain how all of that works in the treatment of epilepsy?
Mm-hmm. Absolutely.
We are going to take a quick break. When we come back, we are going to continue this conversation with Dr. Paul Lyons. He is a neurologist and an epileptologist. This is part of our community health series in partnership with Valley Health. We are recording it on a Tuesday morning. You, however, are listening to it on a Thursday afternoon. We're going to be back in just a couple of minutes.
Do you know anyone who is struggling with financial hardships because of coronavirus? Our new webinar called Coping with the Money Crunch can help. We'll talk about immediate options to consider, revising or creating a spending plan, and lots of community resources. Then we'll cover how to narrow your priorities, contact creditors, and avoid scams and risky loans. The webinar is free, and you can either join by phone or through Zoom on a smartphone, tablet, or computer. You can find out more by visiting the Northern Shenandoah Valley Financial Education Program on Facebook or calling Karen Poff at 540-635-4549. Let me show you how to make your own plan or help someone you care about get through the crisis. Call 635-4549 or visit at NSV Financial Education on Facebook today.
Welcome back to the Valley today. I am your host, Janet Michael. You, of course, are listening to the show on a Thursday afternoon. We, however, have pre-recorded our conversation over Zoom on a Tuesday morning. We are chatting today with Dr. Paul Lyons. He is a neurologist and and because he said during the break that I did such a great job, now I'm stumbling over epileptologist. This is all part of our community health series in partnership with Valley Health, where every month I talk with various doctors, administrators, program directors from Valley Health about a wide range of health topics. Today, Dr. Lyons is talking to us about epilepsy and some of the treatment protocols that are groundbreaking. So, Dr. Lyons, give me an example of an epilepsy syndrome and how you would put some of these treatment protocols in place and what they are.
Great. That's a wonderful question. I'll give you one example. So when we diagnose someone with epilepsy, one of the first questions is how will this impact my life? Will this be a lifelong condition? Will my children outgrow it? And what other conditions can be associated with it? Specifically for kids, will there be cognitive decline? So an example of this is tuberous sclerosis complex. And this is why any patient with seizures should ultimately be treated for epilepsy, because within that, you have a prognosis established, the right drug for the right person for the right duration of time. Before I talk about tuberous sclerosis complex, let me give you a few examples. Let's say I diagnose a child with childhood absence epilepsy. That's an epilepsy syndrome beginning early on in childhood, developing normal children, absence or staring or zoning out seizures with a very classic EEG. That child with 90 to 95% confidence is likely to outgrow the seizures with treatment with medications by the time they're 11 or 12, if not younger. Whereas if I diagnose an adolescent or a juvenile with juvenile myoclonic epilepsy, again, epilepsy occurring in that demographic, developmentally normal, with myoclonic seizures or jerking spells, and typically convulsive or grand mal seizures, with a very classic but distinct EEG pattern, I can tell them that this epilepsy typically responds quite well to medication, but in contrast to childhood absence epilepsy, the probability of growing it is quite low, meaning despite being seizure-free for years, they have a very high risk of breakthrough seizures if they come off of medication in the future. So that's an example of having an epilepsy syndrome as opposed to a seizure type is a hallmark of successful treatment of seizures in patients. So tuberous sclerosis complex is a rare genetic condition, and the most common manifestation of that is seizures. It's associated with two mutations that have been identified on two genes, TSC1 and TSC2. So tuberous sclerosis complex is typically an epilepsy syndrome where children typically in the first year of life develop seizures and have developmental delay. Tuberous sclerosis as a manifestation has two prominent features. One would be unusual skin blemishes or marks, particularly brown spots on the skin or what we call cafe au lait spots. There's also other unusual features on the back, such as ash leaf spots. So another important element of epilepsy syndrome can be medical, such as looking at the skin and getting a history about unusual birthmarks or rashes that can guide us towards a specific epilepsy syndrome. This syndrome itself is also relevant because the epilepsy syndrome, as I mentioned before, in this case in particular, is associated with other manifestations, specifically tubers or benign tumors that can be scattered throughout the body, including the kidneys, lung, brain, and heart. And in the brain, these tumors actually can grow to a point where they can cause swelling of the brain or hydrocephalus and actually can progress to be more problematic. So this is an example of an epilepsy syndrome where there's other conditions associated with it that require a specialized team to focus on all those other organs that can be affected in careful monitoring of those tubers or benign lesions that grow in different organs. So in this case, the seizures, again, a hallmark of epilepsy, is commonly, particularly in the first year of life, what we call infantile spasms. And this is an example of an epilepsy syndrome that must be treated very early to try to minimize the risk of long-term consequences, in this case, regression, severe epilepsy, or autism, and other neurodevelopmental disorders. Infantile spasms is a type of seizure, typically in the first year or two of life. The vast majority of children are not normal at birth, though some can be. And it's a simple, benign little truncal flexion where the baby seems to be like doing a little mini crunch and sometimes can cry afterwards. In some cases, unfortunately, the symptoms can be misdiagnosed as GERD or reflux. So a critical part of this, that is in general infantile spasms in babies, is it must be treated or should be treated in the first 6 weeks of symptom onset, as delay of treatment can increase the probability of a less favorable outcome. Likewise, knowing that it's a very specific epilepsy syndrome, not only will this guide urgency of the importance of treating early and doing genetic testing to look for other organ systems being involved, but the drug we use is very specific. So it's an unusual medication in that it's a peptide hormone, or a naturally occurring little molecule of protein that's injected in the muscle rather than taken by mouth. And this is done typically as an inpatient on an urgent basis. Also, knowing that it's a unique epilepsy syndrome that has long-term consequences that can be grave, we really focus on achieving not just seizure freedom, but also normalization of the EEG. In this way, with the assistance of Layla Hammer and her colleague, Suzanne Lesser, we've been able to develop a dietary program for epilepsy, or ketogenic diet program. And as a result of that, we've been able to achieve seizure freedom in some patients, even when they fail medications. So tuberous sclerosis complex is an example of an epilepsy syndrome that kind of hits on all those points that I've mentioned in the first half of the program, of the importance of diagnosing epilepsy syndrome, establishing a prognosis, using focused testing, in this case genetic testing, guiding appropriate and timely treatment and the right treatment for the right person at the right time, and then helping the family to establish expectations. Not only does regular screening need to be done, including brain MRIs, but also many of these children will develop drug-resistant epilepsy that may require surgery. Many of these children will develop developmental delay, and many of them actually can develop autism spectrum disorder as another manifestation. So guiding them to early life education and therapeutic interventions will also be something, a critical part of an epilepsy program, to make sure that we optimize the goals in seizure treatment. These treatments in any patient with epilepsy are fourfold. It's seizure freedom, as I mentioned before. There's no side effect from treatment, be it surgery, device, medication, or diet. Optimal childhood development in adults, optimal vocational and avocational status, and avoidance of harm. Harm in adults can be car accidents, drowning, falling from heights, and in anyone, SUDEP, or sudden unexpected death in epilepsy, a relatively rare phenomenon. In approximately 1 to 2,000 patients with epilepsy, it can be a cardiac arrhythmia or respiratory arrest that arises from a seizure. And that hallmark, that emphasizes another hallmark of achieving goals, is educating patients on risk of seizures and the importance of achieving seizure freedom and not stopping medications abruptly, as the latter increases the risk of SUDEP or sudden death in epilepsy. Lastly, I mentioned tuberous sclerosis complex just because the FDA recently approved a new medication that we've been involved with here at Valley Health and the research team, approving Epidiolex, or medical grade CBD, for treatment of seizures in tuberous sclerosis complex in ages 1 year and above. And recent studies this year presented at the American Epilepsy Society meeting in December demonstrated excellent response in patients 1 year and above, going up to their mid-50s, with tuberous sclerosis complex and associated seizures. So it's a very exciting new opportunity for treatment that not only do we have for tuberous sclerosis complex, but also 2 other childhood epilepsy syndromes that we were involved with studying and leading to FDA approval. That is Lennox-Gastaut syndrome, another childhood epilepsy syndrome, and Dravet syndrome, another childhood epilepsy syndrome. The journey that we've taken in our program is trying to marshal and organize all these resources to be timely, appropriate, efficient, with resources and care to guide patients through things that can be really scary. It's very frightening to watch a loved one have a seizure, even more frightening to watch someone regress. It's frightening to think about your loved one having a seizure at night that you might not be aware of. And obviously the risk of loss of a loved one is something that we all dread. And so helping people minimize those risks and understand the risks and select appropriate treatments at the right time is something that we focus on in our program.
And you mentioned this Epidiolex, which is a relatively new drug. You mentioned earlier in the conversation that we were having that not all seizure drugs work for all patients. So this has got to be really kind of a breakthrough to be able to find this new drug. You mentioned too CBD oil. So explain to me, or let's clarify that that is not what some of us may have traditionally thought of as marijuana, or this is not a pot drug. These people are not getting stoned when they take Epidiolex, right?
Yes. Yes. So this is a very complicated topic, and I won't go into exhaustive detail, but there's lots of people involved with this. There's every state's Department of Board of Medicine or Board of Pharmacy. So we have 50 of those involved in the dialogue. We have the DEA and the FDA, and then we have our state legislatures, and then we have our federal legislatures. And all those have been involved in creating a story for marijuana and healthcare in the U.S. And where we now stand, with no small amount of confusion for all of us, is that marijuana has two definitions. There's marijuana that has higher levels of THC. There's a form of marijuana that has lower levels of THC, and that's called hemp. But they're actually the same plant. They're both Cannabis sativa, the same genus and species of the plant. So that's one point of confusion, is they're both actually the identical plant. They just have different compositions in terms of the oils produced by the plant products. So CBD is an example of one cannabinoid. And cannabinoids, as you know, are fat-soluble molecules that are made by plants and also made by us in our own body, endocannabinoids. So really what plant-based molecules, they're called phytocannabinoids. Those are in contrast to our own endogenous cannabinoids called our endocannabinoids. And that yet is in contrast itself from those that are pharmaceutically produced that are called synthetic cannabinoids. So CBD, again, is just one of many cannabinoids. So you correctly mentioned that there's two ways to treat a patient's conditions with CBD in this case, which of course is not psychoactive, in contrast to THC. One is an FDA-approved product that's produced by a pharmaceutical company that is exposed to good manufacturing processes, that's produced in facilities where there's the expectation there won't be any pesticides, herbicides, heavy metals, organic solvents, or other contaminants. And importantly, when a doctor prescribes a single dose of a medication from batch to batch to batch, it's going to be the same. So if my patient responds to 300 milligrams of Epidiolex on day one, and 2 years later I prescribe 300 milligrams of Epidiolex, it'll be the same dose. Not that the hemp-derived products don't have a role in human wellness, but in disease management, it's a bit challenging for all of us. One of the products is nationwide, there's no good manufacturing processes or standards for hemp-derived products. Now, there are some facilities that do a superior job producing excellent products. The problem is there's no nationwide way for patients when they purchase something online to know that ahead of time. So obviously, you'd want to make sure that your product is not affected by pesticides, herbicides, or heavy metal. Again, being agricultural products, this is a bit complex. And secondly, you want to make sure there's no organic solvents from the extraction process. And then thirdly, you'd want to make sure that the QA process is such that there's batch-to-batch consistency of content. So those are three hallmarks of a medication and what we expect: safety, reproducibility, and lack of contamination. And those are there's variable consistency in that. There are some, again, over-the-counter CBD products that are, I'm sure, quite reputable and very good. And there are others that are maybe through processes that are not that exacting, maybe a bit more variable. When the FDA has looked at over-the-counter products marketed as having CBD, the composition of CBD in some of the products is spot on and exactly what the label says. In other products, it's all over the place. And some contain no CBD and some contain higher levels of CBD than what's on the label. So that's one of the particular challenges that we all faced. And not that it doesn't have a role in wellness and patients using this molecule that's relatively safe. But that being said, if we're treating something as severe as epilepsy, we really want to make sure we have a product that we, meaning the patient, their caregivers, the family, the health system, and insurers all reliably know will be predictable with responses that are known. So that's a bit of a complex response to a relatively straightforward question, but that's kind of where we are right now as society. And as governments try to respond to the shifting landscape of federal regulations as it comes down through farm bills. And this is a particularly fascinating field for doctors in that it's a combination of agriculture, these are agriculture products grown as products, chemistry, and then pharmacology, along with politics and then business. Unfortunately, but for instances such as GW Pharmaceutical, most of the CBD producers in the country are not leading the way on research. So there's a relative dearth of research on the importance of these molecules from cannabis that I feel very confident will be the source of new treatments for different diseases in humans. It's just a matter of doing exacting, precise, and carefully designed studies that meet ethical guidelines and bring this to products. A last element to the challenge of over-the-counter products is, of course, as they're not FDA approved, insurance won't cover them, and these products can represent significant financial barriers in that they're out of cost cash products, and they can, for many of my patients, can be a barrier to regular access. A last comment I'll make about any of the products from cannabis, particularly the cannabinoids such as CBD, whether it's Epidiolex or over-the-counter formulary CBDs from these compounding facilities, is they're all processed by the liver, so you should be checking liver function tests. And then as they all can impact the liver and its processes or other molecules, you'll need to be aware of what other medications the patient may be on as they can interact with them. So for instance, if someone is on warfarin or Coumadin for stroke prevention, and they take a CBD product, it actually can, there's case reports of that anticoagulant, Coumadin or warfarin, having its level being affected by an over-the-counter CBD product. So whether it's Epidiolex or a CBD product, please make sure that your clinician is aware that they're taking it so they can make sure no harm is done. Obviously, a cornerstone of medicine and surgery. It could be as simple as checking blood work every 3 or 4 months, and also doing looking for drug interactions. And likewise, if you're using this, please let your pharmacist know that you're using this product so they can do drug interaction analyses whenever possible.
Well, Dr. Lyons, thank you so much. I mean, this has been a fascinating conversation. I think we should do a whole series on epilepsy treatments and protocols and the new drugs and CBD oil. I think you've got plenty to be able to explain to me.
No, my wife says you put a microphone in front of me, it's going to try to shut me up. So she's happy I have other venues for talking beside our kitchen table.
Well, thank you so much, though. I do appreciate your time today.
All right, then. Thanks so much. It's been lovely. I appreciate the time.
We are going to wrap up our conversation today with Dr. Paul Lyons. He is a neurologist and epileptologist with Valley Health. This has been part of our community health series, obviously in partnership with Valley Health, where every month I talk to various doctors, administrators, program directors about a wide variety of health topics. We recorded today's conversation over Zoom on a Tuesday morning. You obviously are listening to it on a Thursday. If you want to hear any of the other conversations that we have had over the last few years, go to theriver953.com/Valley Health Podcast. All of the conversations are there, as well as today's show. Tomorrow is Extension Office Friday. Carol Nansel with the Shenandoah County Extension Office is going to meet me on a Zoom screen with some of her 4-H'ers, and they're going to tell us about the 4-H Livestock Show and Sale, how that's going to look this year. Shenandoah County Fair is canceled. However, the 4-H Livestock Show and Sale is going to go on. Meet me back here a few minutes after noon, and I will have that conversation ready to go for you.